Welcome to the Ranong Smart Review Head and Neck Cancer series.
Today, we are focusing on one of the most foundational and, frankly, most frequently tested concepts in head and neck radiation oncology, the dimension of time.
Right.
This is Foundations 5, covering fractionation and time, and why we obsessively protect the finish line in this disease.
We really need to set the stage here with a critical comparison. So think about treating a very, very slow-growing tumor, maybe a low-risk prostate cancer. If the machine breaks down or the patient needs a week off for some family thing, it's a logistical headache, sure, but biologically, the tumor barely even registers that delay. We have a massive amount of temporal wiggle room there.
Exactly. In prostate, the cell turnover is just so slow that a week's delay, it typically has a negligible impact on the overall biological equivalent dose we deliver.
Okay.
So that large therapeutic ratio in time allows for flexibility, which is why we can often do things like hypofractionation, where the time factor is it's less punitive.
But you have to flip that paradigm completely for head and neck squamous cell carcinoma, or SCC. Here, a week off is not just an inconvenience. It is a critical, measurable, biological advantage you are handing directly to the tumor. The urgency is it's profound.
It really is.
So today, we're doing a complete review of this time factor, how overall treatment time, OTT, dictates control, the radiobiology of what's called accelerated repopulation, and how we use altered fractionation to fight back.
And this is the most crucial part for clinical practice and for your oral boards. What precise steps you take when a treatment interruption inevitably occurs.
Because it will happen.
Oh, it will. And when you are sitting in that hot seat, the examiner will inevitably spring this trap. Your patient has missed 3 treatments. They're in week 5. What is your plan? And more importantly, what is the radiobiological justification for that plan?
And if your immediate response is oh, we'll just extend the end date,
You've missed the entire point. The entire point of treating head and neck SCC. We have to treat time as part of the prescription itself, designed specifically to maximize locoregional control.
So let's anchor this whole discussion not in theory, but in a really challenging clinical reality. And this case is specifically constructed to remove your easiest tool concurrent chemotherapy, forcing you to rely solely on the radiation schedule to get a cure.
Okay, let's hear it.
So we're consulting on a 72-year-old male. Epidemiology check. He has a heavy 40-pack year smoking history. That's a massive risk factor for developing larynx SCC.
Right out of the gate, textbook.
And the patient's medical history is really key to our treatment dilemma. He has stage 3 chronic kidney disease with his GFR, his glomerular filtration rate, critically hovering around 25.
Okay, 25. That low GFR is our first critical constraint. It immediately tells me that class 6 systemic therapy, cisplatin, which is nephrotoxic, it's just unlikely to be tolerated or safe. His kidneys are a contraindication.
Precisely. Clinically, he's presenting with chronic hoarseness and significant difficulty swallowing. Odonophagia, dysphagia. On physical exam, we note a fixated right vocal cord. It's a major indicator of T-stage advancement. And we see pooling of secretions, which suggests a pretty significant laryngeal incompetence.
So he's already having functional problems.
Big time. Imaging confirms the tumor involves the right glottis and the supraglottis, and we see definite extension into the pre-epiglottic space.
And that extension, that's an anatomical landmark that residents must understand. It signifies deeper invasion, it carries a higher risk of nodal involvement, and importantly, it complicates your field design.
Why is that?
Well, because it's a pathway for spread, and it correlates with higher rates of treatment failure if your dose isn't sufficient. It's not just a tumor sitting nicely in the glottic box.
Right, it's already spreading.
Yeah.
And we also identify a single 3-centimeter level 3 lymph node in the neck. Biopsy confirms moderately differentiated squamous cell carcinoma. So based on the fixed chord, that's T3, and the node size and location, that's N1, we stage this as a clinical stage T3N1M0 larynx cancer using the AJCC staging system. This is locally advanced disease.
It is. So let's just solidify those systemic constraints again. Medical oncology has definitively ruled out cisplatin because of that renal failure, right? The GFR of 25.
Correct. And on top of that, he has a known history of a severe anaphylactoid-type infusion reaction to a previous monoclonal antibody. So that functionally rules out the EGFR antibody, cetuximab, which is often our substitute.
So he's really tighted into a corner.
He is.
Yeah.
And the critical conclusion is this. No concurrent systemic therapy is available. Radiation alone has to be the curative strategy for this stage T3N1 SCC of the larynx.
And that leads us directly to the consult question, which is really the start of our whole discussion. Given this aggressive tumor and the lack of concurrent chemo, should we just use the conventional schedule, 70 gray and 35 fractions 5 days a week?
And we know, just intuitively, that conventional radiation alone is often inferior to the standard of care, which is chemoradiation. But how do you articulate the necessary intensification strategy in a board-level response without, giving away the whole lecture?
Well, I'd start by framing the clinical urgency first, and then I'd introduce the concept of intensification. So
Okay.
if I were answering, I'd say, this is a 72-year-old male with locally advanced T3N1 laryngeal SCC who is ineligible for concurrent radiosensitizing systemic therapy due to severe renal impairment and prior drug reaction.
Acknowledging the constraints.
Exactly.
Right.
We must acknowledge the established evidence shows conventional fractionation radiation alone to 70 gray is inferior to the concurrent chemoradiation standard for locoregional control of advanced head and neck disease.
Setting up the problem.
Right. Therefore, to maximize his chance for cure and larynx preservation without systemic agents, the strategy must pivot to intensifying the physical delivery of radiation through an altered fractionation regimen, based on evidence from trials like RTOG 9003.
That's a perfect pivot. It establishes the problem, establishes the need for a solution, but you haven't given the specific dose yet. So how do you choose from that menu of altered fractionation options?
Well, the choice is between hyperfractionation, which is all about dose escalation while trying to spare late effects, or an accelerated approach, which prioritizes time compression. Both are acceptable strategies.
So which one do you pick?
For the boards, I would select the hyperfractionation schedule, 81.6 gray in 68 fractions of 1.2 gray BID.
BID, so twice daily.
Twice daily. And I'd choose it because the smaller fraction size gives us the most radiobiological assurance against severe late toxicity in a dose-escalated setting. But crucially, regardless of which one I choose, I'd have to say I'm prepared to aggressively manage the inevitable increase in acute toxicity and strictly plan to avoid any treatment interruptions by compensating immediately.
That response is great. It nails the clinical constraint, it correctly picks the radiobiological tool altered fractionation, and most importantly, it elevates time management from just some scheduling detail to a critical component of the actual prescription.
Which it is.
So now we have to dive into the underlying radiobiology of why. Why is time so important here?
Okay, so the fundamental difference between tumors is their intrinsic doubling time and their capacity to repair what we call sublethal damage. Head and neck SCC is generally characterized by a high alpha-beta ratio, usually around 10 grays.
And what does that high ratio mean practically?
It means that cell killing is relatively sensitive to the total dose, and it's less sensitive to the fraction size than, say, prostate cancer, which has a very low alpha-beta ratio, around 1.5 to 3 gray.
Okay, let's unpack that for a second, because this is where the 6-hour rule and that 1.2 gray fraction size really come from, right?
Exactly. If the tumor has a high alpha-beta ratio, small fractions aren't strictly required to spare the tumor, but they are required to spare the normal tissue.
The surrounding healthy stuff.
Yes. Normal late-responding tissues, things like the spinal cord, connective tissue, cartilage, they have very low alpha-beta ratios, often around 3 gray. These tissues are highly sensitive to the size of each fraction.
So if you go too high on the daily dose...
If you increase the dose per fraction too high, say above 2 grays, you exponentially increase the damage to these slow-dividing, late-responding tissues.
So with hyperfractionation, we're using that tiny 1.2 gray fraction size specifically to exploit the low alpha-beta ratio of the normal tissue. We're maximizing repair there, which then allows us to safely climb the total dose ladder all the way up to 81.6 gray to kill the tumor.
That's the radiobiological rationale in a nutshell. But the immediate clinical observation that's tied to this high turnover rate is that prolonged overall treatment time, OTT, correlates directly and very strongly with worse local control rates in head and neck SCC. This is the difference between a high-stakes time trial and a slow marathon.
It's interesting. Why don't we see that same degree of time dependence in other fast-growing cancers, like certain small cell lung cancers? What makes head and neck SCC so unique in its response to a prolonged treatment?
It really comes down to adaptive kinetics and this phenomenon of accelerated repopulation. While a tumor like small cell lung cancer might be fast right from the start, SCC in the head and neck region is particularly adept at activating survival pathways mid-treatment.
So it adapts on the fly.
It adapts. That high turnover rate allows them to rapidly respond to the selective pressure of radiation.
Let's delve into the mechanics of that adaptive response. You called it the week 4 switch.
Yes. So, conceptually, during the first 3 to 4 weeks of definitive radiation, the tumor has a lag period. Repopulation is modest. The gross effect of the daily 2 gray fraction is generally working. The cell death rate is higher than the replacement rate, and the tumor is shrinking.
But the tumor isn't just passive. It's sensing the stress.
Right. Around the start of week 4, or roughly day 21, the surviving clonogens, these are the cells that are responsible for an eventual local recurrence, they accelerate their division dramatically. This is the kickoff time.
And what triggers that?
It's driven by the release of growth factors and cytokines, often in response to the massive cell death and inflammation caused by the earlier fractions. The tumor's effective doubling time can shorten from maybe 4 or 5 days down to 2 or 3.
That is a staggering acceleration. So you start with a manageable rate of cell growth, and by the halfway point, the tumor is essentially running full speed while you're still delivering the same dose 5 days a week.
And this is exactly why OTT is a critical variable, not just a logistic detail. If you extend the treatment beyond that initial 7-week period, every single extra day is exponentially more costly to your local regional control.
So how do we quantify that biological cost? This is a crucial number for board calculations.
The practical translation, which is often cited from classic radiobiology literature, is the estimated loss of biological effectiveness. You lose between 0.5 and 0.9 gray of dose equivalent per day of prolongation, specifically after that kickoff time around week 4.
Wow. Okay, let's stress test that number. If a patient has a 10-day unplanned interruption, say it starts at week 4.5, and we just tack those 10 fractions onto the end, even if the final prescribed dose is 70 gray, the effective biological dose might be closer to 70 minus 7 or even 9 grays.
Exactly. You may have sacrificed up to 10% or more of your local regional control effectiveness purely by extending the calendar. And that reduction in dose effectiveness is highly predictive of local failure.
So this underscores the core reason we use altered fractionation strategies. They're just mechanisms designed to reduce the OTT or increase the total dose to compensate for this accelerated repopulation.
That's it. The concept is clear. In this disease, time is constantly working against you after the first month.
Okay, so let's make sure we can fluently articulate the 4 main fractionation concepts that are really the foundation here, moving beyond just the doses to the specific role of each one.
Perfect. Let's start with our reference point, conventional fractionation.
Okay.
Conventional fractionation is the standard 70 gray in 35 fractions delivered at 2 grays per fraction, 5 days per week, so a 7-week OTT. Its primary role today is not as a standalone cure for locally advanced disease, but as the well-tolerated backbone for pretty much all concurrent chemoradiation regimens, where the systemic agent is what provides the necessary sensitization and dose intensification.
Got it. Okay, next up, the choice we made for our patient who couldn't get chemo, hyperfractionation.
So hyperfractionation is a pure strategy of dose escalation while preserving late tissue integrity. The regimen residents have to be able to recite is 81.6 gray in 68 fractions of 1.2 gray twice daily, or BID, over about 7 weeks.
And the logic is?
The logic is simple. The smaller fraction size exploits the repair capacity of those late-responding normal tissues, the ones with the low AB ratio, to allow us to safely push the total tumor dose to a much higher level. So we maximize tumor cell kill without increasing the risk of catastrophic late effects like laryngeal necrosis.
And what's the non-negotiable logistical and safety detail you have to mention?
Yes. You must specify at least a 6-hour interval between fractions. If you omit this, you're showing you don't understand the underlying radiobiology required for adequate repair in those slow-cycling normal cells. This 6-hour rule is what protects the patient from unacceptable late toxicity.
Okay, that's critical. Let's pivot now to the strategies that are focused purely on time compression, the accelerated fractionation approaches.
Right. So accelerated fractionation strategies, they prioritize shortening the OTT to defeat that accelerated repopulation. You often keep the total dose similar or maybe just modestly higher than conventional. And the simplest strategy, one we use a lot clinically, is the 6 fractions per week approach.
That strategy is often underestimated in its biological power, I think.
It absolutely should not be. By just treating on a Saturday, you reduce the OTT from about 50 days down to 42 or 43. You're cutting nearly an entire week off the total calendar time.
And that's huge in weeks 4 through 7.
It's huge. That time compression translates directly to a reduction in the accumulated tumor clonidine load.
Okay, and the final technique, the concomitant boost.
Right. Concomitant boost, or AFCB, is an accelerated approach that starts with 5-day-per-week treatment, but during the final 2 to 3 weeks, you add a second, smaller daily fraction. That's the boost specifically targeted to the gross tumor volume, the GTV.
Can you give us the regimen example for the boards?
The classic regimen is 72 gray in 42 fractions over 6 weeks. So you might be delivering 2 grays to the larger PTV, and then later that day, a 1.4 or 1.6 gray boost to the GTV, always making sure you have that 6-hour separation.
So during those final crucial weeks, the GTV is getting a dose of around 3.4 to 3.6 grays per day. That effectively shortens the treatment by a full week.
Yeah.
What's the major catch here?
The major trade-off for the concomitant boost is acute toxicity. While you're achieving a really high biologically effective dose in a short time, the intensity often means severe mucositis peaks very hard and very early in those final weeks. It requires maximal supportive care, and patient compliance can be extremely challenging. You are pushing the acute tolerance edge very aggressively.
Okay, so we can't discuss these fractionation schemes without grounding them in the evidence. When systemic intensification is off the table, the entire paradigm rests on the data from RTOG 9003. This is really the single most important altered fractionation trial for head and neck SCC.
It is. The trial, published by Fu and colleagues, was just monumental. It directly tested whether manipulating the schedule could improve outcomes in patients with locally advanced SCC who are not getting concurrent chemo. It had over 1,000 patients randomized across 4 arms.
Let's run through those 4 arms again and just cite the specific goal of each one.
Okay. Arm 1 was conventional fractionation, the control arm. 70 gray in 35 fractions. The goal was just a baseline comparison. Standard of care at the time.
Exactly. Arm 2 was hyperfractionation. 81.6 gray in 68 fractions, 1.2 gray BID. The goal there was dose escalation while sparing late toxicity.
Okay.
Arm 3, accelerated fractionation with a planned split course. Now, the goal was compression, but they intentionally included a planned mid-course break, usually 1 or 2 weeks.
A planned break. That already sounds like a bad idea based on what we've discussed.
And Arm 4, concomitant boost. 72 gray in 42 fractions over 6 weeks. The goal was maximum time compression to defeat accelerated repopulation.
So what was the primary high-yield finding? What did they learn about locoregional control?
The results were crystal clear. Compared to the conventional arm, both the hyperfractionation arm and the concomitant boost arm significantly improved locoregional control.
By how much? The improvement in 5-year locoregional control was substantial. We're talking about an increase of 10 to 15 percentage points in the intensified arms compared to the conventional arm. It was proof that, in the absence of chemo, the radiation schedule itself can serve as a primary tool for escalation.
Okay, now let's talk about the failure point, which is arguably the most critical teaching moment of the entire trial, that accelerated split-course arm. Despite the initial acceleration, the outcomes for this arm were significantly inferior. It failed to show any benefit over conventional.
And the failure of that split-course approach provides the undeniable evidence for the week 4 switch. The planned break, which they inserted during the exact time frame when the tumor was beginning its accelerated repopulation, it gave the surviving clonidines the precise opportunity they needed to replenish their numbers. It essentially erased all the biological advantage they gained from the compression beforehand.
So this is the required borderline you have to know. A planned treatment break or a mid-course split functionally erases the biological benefit of acceleration. It is repopulation's best friend. It's the worst decision you could make in the middle of a head and neck course.
It is proof that we are in a constant race against time. The meta-message from RTOG 9003 and the meta-analyses that followed is that altered fractionation provides a modest, consistent survival and control benefit, and that benefit is overwhelmingly concentrated in the subgroup of patients who do not receive concurrent systemic therapy.
So to translate that evidence clinically, when a patient is getting cisplatin or another effective radiosensitizer, the intensification is already provided systemically. Our job reverts back to the standard 2 gray per fraction, to prioritize maximum tolerability and completion without breaks.
Exactly.
It's only when chemo is off the table, like in our T3N1 patient with renal failure, that we have to invoke these more complicated, more toxicity-intensive altered schedules.
That's the decision point. And this is where we move from theory to high-stakes patient management. When you're on call or you're in that oral boardroom, you will encounter the interruption scenario.
Okay, let's use the classic examiner's trap scenario. Your patient is on a conventional 70-gray schedule for laryngeal cancer. They miss 3 consecutive treatments, Tuesday, Wednesday, and Thursday in week 5, because of a department issue. We're well past that radiobiological kickoff time. What must be done?
The instant reaction must be to compensate. If you say, oh, we'll just add 3 fractions to the end, you've committed the cardinal error. You've just accepted 3 extra days of highly efficient tumor repopulation at a biological cost of, what, potentially 2 gray or more of effective dose.
So the rule has to be, we must preserve overall treatment time, OTT, by compensating immediately within the same week, regardless of how logistically difficult that is.
Absolutely. So let's detail the compensation toolbox in order of preference, prioritizing that OTT integrity.
Okay, option 1, the cleanest solution.
Treat on Saturday. If the patient missed 3 fractions, treating them for 1 fraction on Saturday reduces your accrued deficit to 2. That's far more manageable. Treating Saturday is the easiest way to restore the fraction count and maintain the planned 7-week end date.
Simple enough. Option 2, the BID makeup day.
Right. If a weekend day isn't feasible, or if you need to catch up on 2 or 3 fractions really quickly, you can use twice daily treatment on 1 or more weekdays. The patient gets their normal daily fraction, and then they return later for a makeup fraction.
And this is where that non-negotiable safety phrase comes back.
It does. The 2 fractions must be separated by at least 6 hours. This ensures repair of those late-responding normal tissues, which is crucial since you're increasing the overall dose burden on that single day.
And I've seen departments that have formal policies for this, like in option 3, for a large-scale outage, maybe using temporary hyperfractionation bursts. What's the goal there?
The goal is simply to catch up the accumulated dose as quickly as possible without extending that finish line. For example, if an outage lasts 3 days, the department might mandate 3 consecutive BID days to immediately restore the timeline. The concept is always the same. Do the work now to mitigate the repopulation.
So the mnemonic is critical here. Make it up, don't tack it on. It's the anti-split course mantra.
Exactly. And just as important as knowing what to do is knowing what not to do. Do not arbitrarily increase the daily fraction size to catch up. A 2.5 gray fraction might seem harmless, but its impact on late toxicity, especially in the larynx, is exponentially higher. It destroys your therapeutic ratio.
Okay, and here's the critical clinical conflict.
Yeah.
The patient develops grade 3 mucositis in week 5, and the medical oncologist calls suggesting a 1-week holiday.
Unless that patient is septic, actively aspirating, or having a life-threatening hemorrhage, you do not stop. A 1-week break is a gift to the tumor. You are recreating the failed experiment of RTOG 9003.
So what do you do instead?
Instead, we intensify supportive care. We place a PEG tube, we give maximal multimodal narcotic analgesia, IV hydration, pain, and mucosal washes. We manage the acute toxicity aggressively while the radiation continues.
Let's summarize this whole decision-making process into the fractionation and time logic tree that we should follow clinically.
Okay. Step 1. Assess systemic eligibility. If concurrent systemic therapy is being given, like cisplatin, you default to conventional fractionation, 70 gray and 35 fractions. Your priority is uninterrupted completion.
Got it.
Step 2. If systemic therapy is contraindicated, you pivot to intensification via altered fractionation, so hyperfractionation or an accelerated approach to improve locoregional control.
Okay.
Step 3. If BID logistics are just impossible, the patient lives too far away, poor compliance, you use the most practical acceleration strategy, like 6 fractions per week.
Something is better than nothing.
Right. And step 4, if unplanned breaks occur, especially after week 4, you compensate immediately using weekend treatments or BID fractions, separated by at least 6 hours.
So applying that logic back to our T3N1 larynx case with the severe renal failure.
The final decision stands. Radiation alone intensification. We use the board clean option of hyperfractionation. 81.6 gray in 68 fractions of 1.2 gray twice daily, separated by at least 6 hours over 7 weeks. It's the maximal therapeutic approach in a radiation-alone setting.
And the patient counseling. It needs to be fluent, and it has to clearly explain the biological necessity. What sounds like a really harsh schedule.
I would counsel them this way. Because your kidney issues prevent us from using chemotherapy to strengthen the radiation, we are adjusting the schedule to make the treatment biologically more effective against the cancer. That means we will be treating you twice a day sometimes, or on weekends, using smaller doses each time. While this schedule is specifically designed to reduce long-term damage to your throat, it will significantly increase the acute soreness and mucositis you experience. So, we will be proactive. We'll likely place a feeding tube now and manage your pain aggressively because maintaining the schedule is crucial for maximizing your chance of cure and larynx preservation.
The shift to altered fractionation definitely carries a steep price tag in terms of that acute toxicity.
Yeah.
So we need to detail the comprehensive approach to managing this increased burden.
Right. Acute toxicity is centered around the rapid onset and severity of mucositis, which leads to adenophagia, xerostomia, profound weight loss. It's often compounded by dehydration and malnutrition. And in accelerated schedules, this toxicity just hits earlier and it peaks higher than in conventional treatment.
So what specific steps do we take proactively beyond just standard anti-nausea meds?
Proactive intervention is mandatory. First, aggressive nutritional assessment. In a high-risk case like this, especially using an accelerated schedule, we often place a gastrostomy tube, a PEG tube, before we even start treatment.
Before?
Yes, waiting until a patient has lost 15 pounds is reactive. We have to be proactive. Second, multimodal pain control. This includes using long-acting narcotics combined with short-acting breakthroughs, often nerve pain agents like gabapentin, and frequent use of topical mucosal cocktails.
And hydration.
Strict monitoring for dehydration, often requiring IV fluids even for patients who are at home.
Okay, now let's flip to the late toxicity side. When we use hyperfractionation, we're escalating the total dose dramatically from 70 up to 81.6 grays. Are we inherently increasing the risk of long-term damage like cartilage necrosis or severe fibrosis?
This is where the brilliance of the radiobiological design comes in. The dose escalation in hyperfractionation, Arm 2 of 9003, is achieved using those 1.2 gray fractions. And because the late-responding normal tissues are so sensitive to fraction size, that small 1.2 gray dose allows for much more complete repair between treatments compared to a 2 gray fraction.
So we're exploiting the repair difference. A higher total dose, delivered in smaller parcels, actually results in a lower biological equivalent dose for late effects than a standard 70 gray delivered in 2 gray fraction.
Exactly. Hyperfractionation trades that increased acute toxicity and logistical complexity for a theoretically reduced risk of severe late toxicity despite the dose escalation. And that makes it a really compelling choice when systemic agents aren't available.
Finally, let's briefly touch on the main toxicity-related controversies that residents might run into.
Well, the critical clinical trap we keep coming back to is the combination of systemic and schedule intensification. Cisplatin is a powerful radiosensitizer. It already pushes acute toxicity to its limits. Combining concurrent cisplatin plus BID hyperfractionation or a concomitant boost is overwhelmingly associated with catastrophic morbidity, poor treatment compliance, and high rates of life-threatening toxicity. It's a dual escalation that is generally unacceptable.
Okay, and the other controversy is around which accelerated schedule is best. 9003 showed that hyperfractionation and concomitant boost yielded similar locoregional control, but the acute toxicity profiles were different.
They were. Concomitant boost with its high dose per day tends to result in earlier and steeper mucositis, while hyperfractionation with more total fractions is often a longer grinding course.
Is there the choice between them?
The decision often comes down to patient preference and clinical logistics, but a resident needs to know that both are evidence-based alternatives to conventional fractionation when chemo is absent.
Okay, let's solidify all this with the critical traps and clinical pearls that residents should have memorized for these high-stakes scenarios.
Good idea.
We've identified 3 critical oral board traps that examiners use to test your mastery of time and biology.
Trap number 1, the combine everything trap. The examiner gives you a healthy patient who is eligible for cisplatin. If you recommend cisplatin plus BID hyperfractionation, you've missed the standard of care.
So you have to pick one lever.
Pick one lever. Intensity comes from either the systemic agent or the schedule modification. When cisplatin is used, conventional fractionation is the default to prioritize patient compliance and tolerability.
Okay, trap number 2, the split course mistake. The patient develops severe gray mucositis in week 4. If you agree to a 1 to 2 week break, you are actively facilitating accelerated repopulation.
The correct move is aggressive PEG tube utilization, maximum analgesia, and continuing treatment. Interruptions are for medical instability, not just discomfort.
And trap number 3.
Forgetting the 6-hour rule. Anytime you discuss BID fractionation, whether for a full hyperfractionation course or for makeup fractions, if you fail to specify at least 6 hours apart, you're demonstrating a failure to understand the safety margin required for late tissue repair. It's a non-negotiable safety clause.
Okay, now let's distill the 5 core clinical pearls that summarize this entire thing.
Pearl 1. Overall treatment time is part of the prescription.
And the context there is protect the finish date rigorously. Every extra day past the expected 7 weeks costs biological effectiveness because of repopulation.
Pearl 2. Repopulation accelerates around week 4.
Context. Delays are disproportionately costly late in the course. The loss is estimated at 0.5 to 0.9 gray of effective dose per day after this kickoff point.
Pearl 3. Altered fractionation matters most when there's no chemo.
Right. When systemic therapy is contraindicated, the radiation schedule, either through dose escalation like hyperfractionation or time compression like concomitant boost, becomes your essential tool for improving locoregional control.
Pearl 4. Split course breaks defeat the purpose.
Context. RTOG 9003 proved that any planned or long unplanned break allows the tumor to replenish its clonogens, completely negating the benefit of acceleration.
And Pearl 5. Make it up, don't tack it on.
Context. Compensate for missed fractions immediately using weekends or BID fractions, making sure to have that proper 6-hour separation to preserve the biological effectiveness of the original schedule.
Perfect.
Okay, let's run a rapid-fire review. I'll pose the question, you give us the best answer and the concise rationale.
Yes, yeah.
Question 1. On compensation. A patient misses 2 fractions in week 5. What is the radiobiologically preferred strategy?
Answer C. Treat on a weekend day or deliver BID fractions separated by at least 6 hours to preserve overall treatment time. The rationale is that immediate compensation maintains the high BED and combats the accelerated repopulation that is highly active in week 5.
Question 2. On the split course. Why did the accelerated split course regimen in RTOG 9003 fail?
Answer B. The mid-course break allowed accelerated repopulation to occur, which negated the benefit achieved by the initial time compression.
Question 3. On hyperfractionation. Which altered fractionation approach allows for safe total dose escalation while minimizing the risk of severe late toxicity per unit dose?
Answer A. Hyperfractionation with 1.2 gray BID fractions. The small fraction size exploits the high repair capacity of late-responding normal tissues, the ones with a low AB ratio, allowing the total dose to be pushed significantly higher for tumor control.
And a final one, on clinical application. You have a T3N1 larynx patient who is eligible for cisplatin. What is the recommended primary schedule?
Conventional fractionation. 70 gray and 35 fractions. The intensity is coming from the cisplatin. The priority is maximizing compliance and minimizing acute toxicity to ensure the patient completes the full course without interruption.
Excellent.
So to summarize this entire session, I think the core principle we drilled down into is this. In head and neck SCC, the time factor is synonymous with tumor control.
Yeah, we've established that accelerated repopulation is the critical mechanism. It kicks off around week 4, making the OTT the enemy. Prolonging treatment beyond 7 weeks just dramatically sacrifices local regional control.
And we rely on altered fractionation hyperfractionation for dose escalation or concomitant boost for time compression when systemic therapy is contraindicated. We learned that the failure of that split course technique confirms that biological time is just. It's non-negotiable.
And clinically, your job is to manage the interruptions proactively. The rule is simple, yet it's hard to execute. Make it up, don't tack it on, always using that safety-critical 6-hour separation for BID fractions to protect the normal tissues.
Exactly. And next time, we complete the treatment algorithm by diving deep into systemic therapy and radiosensitization. We'll be discussing the mechanisms of cisplatin, the controversial role of alternatives like cetuximab, and exactly how those systemic choices intersect with the fractionation decisions and the time factor we covered today.
Complete practice oral boards at radonsmartlearn.com and subscribe to Radon Smart Review for our next session. Thanks for tuning in.